CataractCoach.com, 4 times when you should not operate. These are some really important lessons. There are 4 times when you should not operate. Remember, any surgeon can operate, but it takes a surgeon with judgment, good judgment, to know when not to operate. And that's such an important lesson to learn in your training. Because as a young resident in training, this pearl goes against your flawed thinking. Because the thinking as a resident is, I want to maximize the number of surgeries that I perform because I want to increase my experience in the operating room. But remember, the mark of a great surgeon is sound intra-operative surgical judgment, as well as the ability to decide when not to operate. So the first case situation I want to tell you about is when patients have unrealistic expectations. Patients must have realistic expectations regarding the potential results of surgery. Let's be frank here. There's no surgery that turns back the clock. I can't take a 72-year-old and give them the vision they had when they were 22 years old. Not going to happen. So patients have to understand that in all surgery, no matter how safe or seemingly simple, carries some degree of risk. There's no surgery that has 0% risk. And though it sounds obvious, we have to remember that we're operating on our patients' eyes, right? Their most precious sense. Patients are going to see the world every waking moment for the rest of their lives through your surgery. So surgical procedures that I routinely perform, like cataract and refractive, they have limitations. We have advanced technology IOLs, but none of them perform as well as the natural human lens in a young person. There are no man-made body parts, whether it's a lens implant, a heart valve, an artificial hip, that are as good as being 22 years old and young and healthy again. Does not exist. Same way, there's no plastic surgery that's going to make a 70-year-old look like a 20-year-old. None. So when patients expect surgical results that are beyond what we can deliver, it's best to avoid performing surgery. Now, the second situation is when the risks of the surgery outweigh the benefits, especially in a reoperation. Ocular tissue is delicate, and for reoperations, every subsequent surgery is more difficult than the previous, and the tissue is less able to handle the procedure. A good example of this is the corneal endothelium, which tends to lose cell with every intraocular surgery. For a patient with a borderline endothelial cell count and increased corneal pachymetry, you better be very cautious about performing another surgical procedure. You got to balance the potential benefit of your proposed surgery with the potential risks, which are now higher because of the condition of the cornea. So you have risks that are a little bit higher and benefits that are a little bit lower. The same can be applied to retina surgery, glaucoma surgery, even strabismus surgery, where the tissues can only take so much surgical intervention before deteriorating. Be cautious. Number 3, when patients have unstable or serious systemic medical issues. We have to remember to look at the whole patient, not just the eyes. Even though our intentions may be good, sometimes performing ocular surgery in patients with grave medical issues may not be in their best interests. Recently, I saw a patient in consultation with advanced cataracts that gave him 20 out of 100 vision in both eyes. He wanted surgery badly, but he was having issues with a number of serious systemic medical problems. So he made a decision to defer his ocular procedure until after he was declared stable by his primary care doctor and his cardiologist. Now, remember, the eyes are certainly important for daily functioning, but a perfect result from ocular surgery is not possible or even useful if the patient expires from the severe systemic medical conditions. So treat the patient first, then the eyes. And if you have a condition like a cataract, it's been there for years, and delaying it another month or 2 while your systemic health is optimized is not a big deal. While cataract surgery can reasonably be expected to last the duration of the patient's life, the same may not be true for other ocular procedures like glaucoma surgery or complex such as sewn-in IOLs. The longevity of our surgical result is an important consideration, especially for younger patients. Using a technique such as intrascleral haptic pocket, the Agarwal glued IOL technique, or the 4-point fixation with the Gore-Tex with the IOL through the sclera, that may be a better choice for long-term IOL fixation when compared to sewing technique using a delicate 10-0 polypropylene suture. So a procedure that's expected to have a limited functional year time frame, it can still be appropriate as long as the patient understands the likely need for a reoperation in the future. And our fourth and final one is, don't operate when the patients would fare better by seeing a different surgeon, another subspecialist. So surgeons tend to gravitate towards fields that interest them, and with time this becomes a narrower and narrower focus. So every year I learn more and more, deeper knowledge about less and less. And so now anything cataract, I breathe it, eat it, sleep it, drink it. I love CataractCoach, right? So when we're in our training as a resident, we know a little bit about many specialties. But as we mature surgeons, we tend to super specialize, so we know a tremendous amount about a narrow range of procedures. There are times where patients present with an ocular condition that's outside my area of expertise and comfort level. It is far better to refer the patient than attempt to do a procedure that's beyond my level of surgical experience or skill. A good example of this is, you see a patient who needs 4-point sclerofixation using Gore-Tex of an IOL. Okay, I can do that. I have many videos of that. This patient has extensive retinal pathology, vitreous prolapse everywhere. The existing IOL is halfway in the vitreous body. Stop. This is not a case for me to do. A retina specialist should do a full pars plana vitrectomy, take out all the vitreous, check all the retina, the peripheral retina, make sure it's all normal, laser any weakness, and then let the retina specialist suture in this 4-point fixation IOL. You're better off that way. So patients must be involved in the decision to operate, and they must actually want to have the surgery. The patient must want the surgery more than you want to give it. If you asked a person out for dinner and the person said, okay, fine, I'll have dinner with you, do you still want to go? No. But if the patient says, oh, I would love to have dinner with you, now you're excited, now you want to do it. So the patient has to want surgery at least as much or even more than you want to give it. So patients who reluctantly agree to surgery are the ones who tend to be the most difficult to please after the surgery. And remember, once you do surgery on a patient, in a sense, you own that patient for life. And the converse holds true. The patient owns you for life. Any future ocular issues may be perceived as occurring due to the effect of your surgery. And that may not even be the case. So remember, depending on the situation, sometimes the best surgery may be no surgery at all. Something to think about. Thanks for watching. Thanks for watching these videos. And remember to go to CataractCoach.com and sign up for a free daily email. We'll send you an email every day with a great video like this and other surgical pearls that'll make you a better surgeon.